you for attending this afternoon's Advances in Autism Research and Care webinar. Before we get started with our presentation, I just wanted to give you a few points for our session today. So if you'd like to ask questions of our presenter, you can type your questions into the questions bar, and we'll have time at the end of the session for Q&A. Additionally, there is a chat bar for discussion during the session, and just a reminder that today's session is CME credit will be offered for today's session, and a link to that evaluation will be sent out afterwards. So now I will turn it over to Dr. Wiley, who will be presenting for us today on autism spectrum disorders and hearing impairments. Dr. Wiley?
Thank you. It's a pleasure to be here, and really excited to be able to speak to the ATN around a topic of passion to me is the dual diagnosis of autism spectrum disorder in children who are deaf and hard of hearing. So hoping my slides are going to work. I'm a little new to this, but all right, there we go. I have no conflicts of interest. I don't get paid to promote this, but our objectives today are to kind of go over a little bit about the epidemiology of autism spectrum disorders in children who are deaf and hard of hearing, give a little bit of backdrop of the ability to recognize atypical development in children who are deaf and hard of hearing, and then also kind of hit upon some of the family perspectives and unmet needs within children with the dual diagnosis. So if we think about how many children with autism have hearing loss, it's a good question to consider. There's kind of two ways to craft that. One is among kids with hearing loss, and one is among those with autism. And Rosenhall had published that about almost 8% of kids with autism, when tested fully with a good hearing battery, had a mild to moderate permanent hearing loss, and about 3.5% with profound hearing loss. If we look at it from kind of the other framework is among kids who are deaf and hard of hearing, what are the rates of other issues? And I think what is striking about kids who are deaf and hard of hearing is that about 40% of them will have some issue that is not really directly related to the hearing loss, such as an intellectual disability and so forth. And the range of percentage of kids with hearing loss with an autism spectrum disorder in the literature kind of goes anywhere from about 1.7% up to 7%, as compared to the general population that perhaps is higher. However, there are some issues with how we determine whether or not kids do have an autism spectrum disorder. So we'll kind of cover some of that as well. If we think about just the epidemiology of hearing loss, at birth there's about 2 to 3 congenital moderate to profound hearing loss. And by school age, you get to 6 to 12 per 1,000 with anywhere from mild to profound hearing loss. Some of that's related to our screening methodology really doesn't hit mild hearing loss and the contribution of progressive hearing loss. Again, if we try to look at different data sources for the occurrence of autism within deaf and hard of hearing, Gallaudet Research Institute is a survey mechanism that looks at children within schools and gets educational data on these other labels. So they come in at about 1%. There's a paper by Jur that looked at about a 4% rate, and Szymanski, who had kind of looked at a number of these different studies and tried to pull them together, put forth an estimate of about 3.4% among children who are deaf and hard of hearing. I think when I think about that is why would that be? Sometimes the etiology of hearing loss can contribute to risks for autism. Particularly, you'll see a little higher rates in kids with congenital CMV, and there's been some question about the role of CMV in blood spot testing in kids with autism, so is there an association there? Some people with newer criteria for Charge syndrome actually include autistic symptoms within their framework. But I think the flip side is it's important to realize that hearing loss doesn't protect you from autism either. So we've had some kids with very non-problematic or what's deemed non-problematic causes of hearing loss like connexin who also have autism spectrum. And is there something different in their genetics and in their family history that would prompt that autism to occur? This is also from Szymanski, who tried to look at the rate of autism over time among children with hearing loss. So she looked at it over different time frames as well as severity of hearing loss. And what you'll see is in each cohort of each grouping, we see an increase in the rate of autism similar to what we've seen in the general population, and then the kids with profound hearing loss being at the highest risk. Again, this data may not be perfect, but it's the best we have at this point in time. What I think, and this is a little bit of old data as well, but we do know in kids with hearing or without hearing loss, however way you want to describe them, the age of diagnosis is older than we would like. But what Mandel found back in 2005 is that with kids with hearing loss, they tend to get at least a year later diagnosis than the general population. And what we've seen in our own group is a really broad range of the age of diagnosis of autism, anywhere from over 3 years to 15 years. And what we typically see is that kids, their hearing loss is identified sooner than the autism, which makes sense with newborn hearing screening. But even with that late age of identification, it really limits our ability to focus on autism-specific interventions at young ages. And what I think really gets tricky is sorting through the impact of hearing loss on language development and the impact of a more significant language impairment such as autism spectrum on language development. So the way I want us to think about this is to start with, what do we think kids with hearing loss should be doing in terms of language growth and language trajectory? And I used to be much more of a person who would go, well, let's see what the hearing intervention does first and let this unfold. And I've kind of shifted my framework, because with this early newborn hearing screening, kids with hearing loss who are identified early and intervened appropriately are having language outcomes in the average range. So they're not pristine, they're still, they're not hitting a mean of 100, but because we see this improved language trajectory, we should be much better about recognizing those who are not following the typical trajectory. So this is some data, some early data on the impact of newborn hearing screening, and what you'll see is in kids who are identified early, what are their language quotients or scores at 3, those early identified kids are getting into that low average range. With the kids being identified later, falling in that sometimes more than 2 standard deviations below the mean. So yes, the late identification is still affecting language, but those with early and good intervention really are making up some nice progress. If we also think about what do deaf children need to process language, we definitely need to have good language environment, whether that's auditory or whether that's visual, because really children have to do a lot of dividing attention. They have to focus on what we're talking. They may have to focus on what we're saying, whether it's through speech or sign, then put it back to what we're talking about, retain that in their memory, and then integrate it into the information with that language input. So even when children are auditory, oral, or lip reading, they do need to look up at that face to get that salient information. If they're signing, they need to be able to see that through their periphery, and really deaf parents of deaf children recognize this need for visual processing and will pace and wait. We also see challenges in incidental learning in kids who are deaf and hard of hearing, and really why I put so much emphasis on this at this point is the fact that one of the things we really need to be doing for kids who are deaf and hard of hearing is helping parents, and with parent training and using our educational systems to promote these modifications for language learning. But in the face of receiving that, then we should be seeing some good language progress. What I think my other thing that I've come to see over the years of seeing kids and kids who are deaf who don't have autism and kids who are deaf who do, is that their nonverbal communication behaviors really should be similar to hearing children. We really should see those eye contact, that pointing, that joint attention. Now, I'd also say that it's important to recognize that gestures and signing are different. So there are different neurologic underpinnings, and gestures are great. It's a foundation up to a more abstract signing, but that we really want to see that signing is something very different. In fact, functional imaging studies would suggest signing is in the language area of the brain. There's been there's been imaging studies on adults with strokes who sign and the sign patterns that they have when they have a language injury to the brain. So it's a bit different, but we still should see that gestural communication moving to an abstract sign in those who sign. So when might you suggest, or when might you suspect autism in a child who's deaf and hard of hearing? Well, any of those same worries we have for kids with autism. Any of those problems in pre-linguistic communication, joint attention, eye contact, requesting, showing, turn-taking, choice-making. I'm going through this a little bit quickly because I'm assuming that as people who see kids with autism, you already know these factors. Where children who are deaf and hard of hearing with an autism may not have the clarification strategies that other kids do. They may not be aware of misunderstandings. Sometimes that can occur because kids didn't hear well, they are not keeping up with conversation, if it's a group of peers, but more commonly for autism, for those with the dual diagnosis, they're not even aware that they could be misunderstanding. They also may have difficulty integrating information. They may be limited in how they ask questions or for what purpose they ask questions. I love to talk about language functions when you look at children and what their function of their language is. In kids with autism, there's a reduced range of language functions, same thing in the dual diagnosis, and then the gaps in social understanding. There is some literature to suggest that kids who are deaf and hard of hearing have limitations in theory of mind, which are more similar to kids with autism than hearing children. I think that some of that is also really based on language levels, and we'll talk a little bit more about that as well, because I think where a child's language level is a real key component to figuring out how atypical they are. Where is that language foundation? What would you expect with their interaction, social communication with that language level? What would you expect with that play at that language level? But I bring us to some tools that we use commonly in children and hearing children, mainly to kind of highlight what are the features of these tools that don't fit kids who are deaf and hard of hearing. So when you look at some of the pre-linguistic red flags for autism in hearing children, really the only one that doesn't fit is turning to your name when called. And again, that only actually fits if a child is not amplified to the place where you would expect them. If they're well amplified and are at a mild hearing loss, they should turn to their name being called as well, particularly if the environment is quiet and we would expect them to be able to listen and attend. So I think, if we think about the EMchat as well, what are the things that could be related to hearing loss and what are the things that could not be? I think anytime we use any tool, we have to really interpret these symptoms or behaviors and look at them within the framework, as I said, of their language level, play schemes, and social interactions. Are they discrepant with, and is that more concerning for an autism spectrum, or are they commensurate, which makes us feel a little bit less worried about autism? So again, just quickly looking through the EMchat, have you ever wondered if your child might be deaf? Of course, that's one that most people with a child who's deaf or hard of hearing might have say yes to. But what I see clinically, that answer may not really kind of fit. But sometimes you'll have audiologists say, I'm pretty sure I've amplified them well. Their hearing aid should be fitting their pattern, but they seem to be more deaf than their audiogram or amplification should indicate. For me, that is actually a red flag for autism in kids who are deaf and hard of hearing. Another one would be, does your child respond when your name is called? And the adaptation here for kids who are signing would be, there are many appropriate ways to gain attention through sign language, whether it's waving or tapping, and kids should respond to those social norms. I've had some deaf parents of deaf children who say, we can't get our child's attention. We in our usual ways, we tap, we wave, they won't look at us. We can't get them to look at our signing, and that then really is a red flag for autism in these kids. What's a little tricky in this, I put it in blue because I'm not sure if it's a plus or a negative for kids who are deaf and hard of hearing. You might think that kids who can't hear well won't be upset by noises. Some kids actually are a little sensitive, or if they're over-amplified will be sensitive and perhaps not have an autism spectrum disorder. So that one's an iffy one. And then the last one is, does your child understand when you tell him to do something? And again, we all know that's really more related to language than specifically autism. But I think these are those were the only questions really when I look at all of these others that don't quite fit kids who are deaf and hard of hearing. So I'm going to spend a couple of minutes here looking at some different videos, and this is the opportunity that if you want to do a little chatting, I'm not sure I can see it all, but what I want you to look for in this first video is we have 2 toddlers signing in the car, and I want you to look at how they do conversational exchange, where their eye contact's going, and kind of think about those nonverbal communication and how they're doing that or not doing that. So you can see them both really looking at Dad, and they wanted him to see what they're talking about. They're pointing to the object. They're looking back and forth, saying "I love you." Now they're talking to each other. So I think you get the sense there that there's a lot of things going on between those two that really convey a lot of good communication, a lot of that, even when you don't know the signs and you're not looking at the captioning, that you really get a sense of communication and joint attention and turn taking. I'm going to do a little bit of this next video. I'm going to do the caveat. Here's my one, I don't know, it's not it's a little bit of an advertisement, basically. So it's an advertisement for an oral school in our area, and I am not endorsing the school, although it is a good one. What I'm trying to capture is these are kids that are oral in an oral deaf school, and so you may get a little bit of clip it back and forth between selling the school, but what I really want you to look at when you're watching this are how the kids are interacting and engaging, and what they're all doing, and how really typical they look. So bear with me while I find my spot.
Sound. Access to sound before the age of 3 can change their success rate in mainstream schools from 52% to 84%. At Ohio Valley Voices, the average child speaks within normal limits by age 6 and is prepared to enter school with their hearing peers.
I want to be a teacher so I can teach kids how to learn.
And with early detection of hearing loss and immediate therapy, they have a 30% higher chance of speaking within normal limits in kindergarten. Ohio Valley Voices is the only program of its kind in the region that teaches children with hearing loss to listen and talk. Our primary goal is for children who have hearing impairment to leave our program speaking within normal limits and reading at or above grade level with a remarkable 3-to-1 child-to-therapist ratio. Ohio Valley Voices' success continues to grow.
When we came in, we met instantly the kids were running around, and we were just like, they're laughing and they're playing, using a unique.
So again, this wasn't the perfect way to find oral deaf kids, but it was the best I could find in terms of just even seeing their engagement, their eye contact, their engagement with their teachers. This next video is again a more typical kid, and this is a rather old video, but the first session, I'm not going to show the whole thing, was a hearing child doing some different play, and then the second was a child who is 3, who is having structured play with the therapist, but again I want you to kind of focus in on that eye contact, that clarification. So she's got some clarification strategies here. We'll just kind of get going on there.
Daisy, the baby wants to go to sleep. Right. What did she do? Baby's sleeping good. Breezy, Mommy wants to kiss the baby. Nice.
So she looks up a lot for clarification. She's following the directions nicely.
Gracie, what are they doing? Right. What are they doing? Right. Are mommy and baby jumping? No. What are they doing? Now baby is jumping. Right. Now mommy is jumping.
So I think on that one, what I thought was striking is that even though she didn't quite know what to do, she decided she was going to take that information and do something with it. And you'll see that a lot in kids who are, typical kids who are deaf, that they're going to show you what they know. They're going to try their best. Uh-oh, I've kind of messed up here. Sorry. All right, in my last video, my last short clip is this one. Is a very short clip on a child who's deaf with autism. It's a family YouTube, but you can take a peek at that one.
What do you want to push? No. See, he wants his drink on the table. No. He doesn't want the lid on the street.
So he really has limited strategies to communicate. He is not really, he'll look up eventually, but he's doing a sign frequently and then not really taking that to the full communication. So very much what we see in kids with autism. Alrighty, sorry, alrighty. So I think the other thing that I have kind of learned over time is sometimes when I look back at my descriptions, I realize that I noticed something before that I didn't really attend to. This isn't quite that, but it's a little boy who had received a cochlear implant, and he was not making progress, and it became more clear that he looked like he had features of autism spectrum. So what were those features that the psychologist noticed? You know, after his implant, he was actually getting good aided sounds, but his interactions were variable. It required physical prompts to get his attention. He also seemed sometimes quite surprised when prompted to interact. So again, the therapist had to, or the psychologist had to put his hands on the speaker's face or physically turn him to get him to attend, and then he would. There was another little girl who we eventually diagnosed with autism as well, and this is where I would say I saw stuff at the beginning that I didn't quite key into. One of the things that she enjoyed doing at pre-implant was watching things drop, so she would drop the toys and really watch at that. She would give up quickly, and I felt like at times she had nice eye contact, but sometimes it required persistent physical prompts to get her to attend. She had difficulties with imitation. What's interesting is she presented later as a child with their implant who she would shut her eyes in the booth at school, and I initially thought maybe she had selective mutism. That was her way of shutting things out. And her persistence and her ability to do this was really striking. She sat for an hour in my office with her eyes shut. She did eventually get an ADOS and as well as an evaluation through a school for the deaf, and felt like her communication and her nonverbal communication really did fit autism. But when you go back and you kind of go, it took me a lot to get them to attend, that's exactly the same thing we see in hearing kids. So some of the key features which are not different than autism is preferring objects over faces, getting eye contact by bringing objects up to the face, imitation being difficult, difficulty shifting without a visual cue, restrictive play schemes, and I would also say that I've definitely seen my share of regression. I see a lot of kids at early on at their diagnosis or near their diagnosis or around time of implant, or in that first year to year and a half, and I've definitely seen kids come back who I feel like have become less interactive, less engaging, and families have also said, yeah, I think there's been a loss of skills. So the tricky part is, do we diagnose, and are we overdiagnosing or underdiagnosing? When we underdiagnose, then we really can't get the right intervention and the right gains later in life. And if we're not accessing those services appropriately, we actually do a disservice. But the flip side of that is we can also overdiagnose, and we can attribute things such as a short attention span or other language disorders, and that may actually not be appropriate either. What I have found, and I think others have found across the U.S., is sometimes the dual diagnosis limits where children can go in terms of therapeutic systems, and I've had that on both ends. I've had schools for ABA schools for autism say we can't handle you because you're deaf. I've had deaf education placements say I can't handle you because of your behaviors related to your autism. So it can be a little bit tricky. I think one of the things that we just really need to be thoughtful about is keeping a strong differential diagnosis and really having skilled assessment to delineate that correct diagnosis. But even I think there are times too that I say let's proceed as if and see what the interventions give us, and that can really help delineate as well. I think the other thing that can be pretty tricky is our standardized test batteries aren't always appropriate for all kids who are deaf and hard of hearing. These are just kind of a quick lineup of the assessments we often use for kids for autism spectrum. There are folks who would argue the Stanford-Binet is not appropriate for kids who are deaf and hard of hearing, particularly if they're not aided well and not really having good oral language. The Mullins at a young age and the Lighter at an older age with much more nonverbal skills are a little bit deemed more positive by those in the field of deaf education, but that also limits us in our understanding of the impact of their language skills. We know that ADOS is not reliable or is supposed to be administered to kids who are deaf and hard of hearing or through an interpreter, and that can also pose challenges. But it becomes tricky if we don't use some of the gold standard strategies. If we're not using the diagnostic criteria in meaningful ways, it almost feels like we're doing kids an underservice who are deaf and hard of hearing by not at least trying to use some tools and then interpret them appropriately. I am aware of one group I think in the UK who's looking to build an ADOS through sign language. So they've gone through a process to understand how to modify this, and then they're going to validate it. So eventually that may be on the way, but I think it's tricky. So, I've already kind of hit, there's a lot of challenges in assessment, the lack of standardized assessment tools. I think the other really key factor, some of the key factors are that providers may be trained in deafness or autism spectrum, but not both. And getting that cohesion across the knowledge is really tricky. I speak a lot to folks in the field of deaf education and deaf intervention, and they are often saying, I recognize this kid is an atypical learner, and I send them to my program that assesses hearing kids with autism, but we hear back that people aren't comfortable and they say they're not doing that because they're deaf. And yet the people who know deafness have already said, hey, this is atypical, I'm very concerned about this. So we really need to partner better to understand what those referrals mean and why they're saying what they're saying, and how to really respond to that. It's pretty tricky to kind of understand the complexity of needs of deaf and hard of hearing children. So if a child who's deaf and hard of hearing enters an autism program, how do we take what we know about their needs in communication around their hearing loss and apply it within that framework? Now, I will get to this in a bit, but I would certainly say that what I see working for communication is really a very multifaceted approach. What I know from autism is what I apply to the kids who are deaf and hard of hearing with autism, more so than what I understand about kids who are deaf and hard of hearing. And I think we all recognize that even in hearing kids will act differently in different settings, so that multiple sources of information is helpful. How are you in the school system? How are you at home? What do you do with peers in different settings? Another tricky piece is when we do need to use interpreters, how can that get embedded in our assessment? So some interpreters are embedded in mental health systems, and they are trained to recognize and observe differences in language features, whether that's low language, whether that's mental health, but many interpreters really don't recognize or convey the atypical language features if they do note them. And obviously it's difficult to figure out the rapport, the social reciprocity when going through an interpreter. So if you take a child with autism and deafness, and do they understand the interpreter is speaking for someone else? That's a pretty high level use of an interpreter, even among typically developing kids who are deaf and hard of hearing. So that can be tricky. And then what is the role of that interpreter? It's also kind of intriguing. There's been some work on the language features of ASL users in those who have autism spectrum, so deaf with autism. And interestingly, I would say the features of language atypicality are very similar to that in hearing, but just in a visual language. So you'll see palm reversals, which is to some degree palm reversals help you know who am I talking to. So if I continue to wave bye-bye to myself with my palm to my face, that's a pattern that typical kids will do, but eventually they turn around and wave to someone else. Well, we see this in signing deaf kids, that they continue to sign to themselves rather than their communication partner. They may avoid pronouns or do pronoun reversals. I've seen sign echolalia, and it's really intriguing. I had one girl who signed everything the interpreter signed. She got really excited about it. She was also a girl who I worked with as a fellow in a camp, and she was in a camp with kids who were deaf and hard of hearing, and she would sign anything they signed. And the kids would come up to me and say, why does she sign everything I say? Now, some of that seemed to me from a functional perspective for her was to process and understand. So sometimes she'd sign back an instruction and then go do it. And other times it really was a function of staying involved in a conversation, but that was the only way she knew how. So very similar to kids with autism. What you also sometimes see is a persistent use of idiosyncratic or their own gestural systems rather than known signs. So you can try to teach the right signs, but a kid might continue to sign red instead of ketchup. Sign spacing is actually an important component of how space is used. What you'll often see in kids who are deaf with autism is their sign space is lower, more avoidant of the space, when most kids will actually sign closer to their face because the facial expressions add grammar to what we're processing. And so what it seems to be is that they're kind of pulling away from that, and whether that's just too hard to process, it's hard to say. But it's interesting to see these language atypicalities in sign language are really quite similar. So it's kind of tricky when around intervention. So if we can figure out you have it, now what do we do? And what is really striking is the evidence behind interventions is sorely lacking for kids who are deaf and hard of hearing, and mostly they're based on case studies. So case studies of PECs or a social communication curriculum. But that being said, it makes sense to go ahead and at least try to think about how what the interventions we have for kids with autism would apply to deaf and hard of hearing children, and what might be some of those adaptations. So again, if we think about what are those foundational elements of communication, it's pretty frequent that I have to have conversations where we back up the train, even if you know some signs or some words, to get us back to that joint attention, turn-taking, choice-making, imitation skills that are so needed to build the next level up. I have definitely seen where implementing picture exchange communication while still maintaining the interest in oral or sign is effective because it helps that visual static representation of language get linked to that language that's more transient, that's either spoken or signed. Technology outcome, using gestures, sign, spoken language, we really have to think broadly. So I think the other thing that I tend to think about when I look at communication for deaf and hard of hearing children, and really with a multitude of issues, but the input and the output may be different. And I think why that's important is we probably as developmentally trained people already recognize that within the field of autism. But within the field of deafness, often families are picking a communication mode. So if your child is oral, why would I need a sign language interpreter? If you're listening and learning in that way, why would I add the sign language interpreter? Well, if my output is signing, how am I going to learn more signs if I don't have the exposure? So it can be tricky to kind of navigate that system for families in terms of getting the right services to help build an effective communication system. I think the other piece is sometimes our kids are in systems that are looking at the hearing perspective. So for example, if you're not responsive to your cochlear implant, it may not be that the cochlear implant is failing. It may really be a core issue of autism. And until we target the core symptoms of autism, we're not going to make the other communication progress. So just thinking kind of broadly in that way. We've hit these first two bullets already pretty well. I think the other ones that I think about are just the sensory sensitivity. So a lot of times kids on the autism spectrum will have more device resistance. They don't want things around their ear. They may need a lower amplification or a lower map in their cochlear implant until we can build it back up. Do we have to partner more with OTs for desensitization, or behavioral specialists, or social stories to help acclimate to the sound input, and also allow them some breaks from time to time, just as we would a hearing child with autism, as let's find a cool down space where it's not as noisy. And then the use of assistive and augmentative communication devices is also really often very helpful. We looked at about 24 kids with autism spectrum and hearing loss and tried to kind of indicate what were their various communication strategies and modalities. And really what's striking is, quite a few of them had more than one modality, and behavior was not an infrequent one. But we do see kids who use oral communication, sign communication, augmentative communication. So again, in speaking with families, sometimes they feel like you're taking a step back, but it can often bridge you to the next step forward. We think about interventions for social communication. I think probably, we know parent training and social skills groups and social stories, but the big question is, who is the peer group? And I think that is somewhat fraught in the deaf education world. So there are folks within the signing deaf community who would say signing in a deaf community is where they're going to have their peers. And that may be the case if they're signing, but some kids really do integrate with the hearing world, or how do you learn the cultural norms for both? And really you have to look at foundationally what is the child doing and what are they needing, and how do you build them to that place. So I don't know that I have a great answer for who the peer group is, but more as much as it depends. If we think about other interventions like LOVOS or comprehensive developmental approaches, I think these all have merit. Again, we have to, the part of the effectiveness of these programs is beginning early, and so when we delay our diagnosis, we're losing out critical time, and then promoting these typical peer interactions, and kind of what does that mean for kids who are deaf and hard of hearing. We've done a little bit of work with families and with professionals. So we did some focus group work, and we started with a professional group. So these were folks from the world of deaf education, those from the field of autism spectrum, and those and audiologists, and those that we knew had already worked with some of the kids that we had diagnosed. And they talked about a number of things, including educational settings, medical and educational teamwork, and role of interpreters. So just to kind of highlight some of these aspects, particularly the educators, recognized that we were trying to ask them what's the best setting for deaf and hard of hearing kids to land in, and the answer was the setting is really child dependent, and what the focus ought to be is what is the behavior or ability that is most interfering at that time. And so that may look different at different points in time, and it may be that an autism classroom at one point is the best place, but then a signing integrated program or an oral integrated program is a more appropriate one down the road. They recognize that one of the challenges is that these kids require many different resources and providers. And in some ways, sometimes the educational system has a better ability to partner and bring in providers from deaf education and the autism spectrum world to build a good program for kids. Although I'll take a side step of my own, is that the educational category can actually hinder or help in this way. With having to have one primary label, that can be kind of tricky. They also, though, discussed about the fact that peer communication is essential, and that probably deaf education programs offer better ways to facilitate communication in social settings. And that they also all recognize that visual supports have really been effective, and that hands-on education is motivating. Things that are tactile and experience-based were highly motivating for their kids who were deaf with autism. They unanimously agreed that the most important aspect of serving children better with ASD is collaborating across medical, therapeutic, and educational settings. So we're really not linked very well, and how can we do that better? They felt that cross-discipline training would be really key. So if we could actually give presentations from both sides and learn in that way, helping understand the impact from the other side, whichever side you're standing on. But they felt that this cross-discipline training was important because we may not be bringing always a united front for recommendations to the families, and that families could get on board a little more quickly and a little more readily if we were a little bit more cohesive in that. I think what families sometimes describe is they had to adapt to the diagnosis of hearing loss, and that was the first hit over the head, and then the second is this label of autism spectrum. And when talking to families, what you'll sometimes hear is, all my network was with, my family-to-family networking was with other people of children who were deaf and hard of hearing, but I have something different. My kid's not doing what they're doing. And if our professional network can't support those recognition of differences and what to do, I think it puts them in a pretty tricky spot. They also, again, kind of spoke to the fact that there's this different performance in different settings, and we need to be careful about our recommendations. I think this was probably more from the educational setting to the medical setting, is that, when you say this child needs X, Y, and Z, and you don't really fully have the picture of what's happening here, it puts the school in a tricky spot. And I know we advocate well for kids, but I think, it's a really important component to think about. There may be things happening at school that we're not seeing that are really valuable. They also felt like there was an important component to do cross-discipline communication, and it was hard to just determine what was the best method, whether we email or whether we have meetings, or and it may not be the same for all families, and what's the necessary information, and the challenges around, from a clinical side, not being a billable service, but even from the deaf educator itinerant side, is if I had to have a team meeting at intervals to make sure we're all on the same page, I'm having to show my direct service hours, but this other consultative time doesn't get wrapped into my contract, and that can pose challenges to be doing the right thing for these kids. We also did a parent group, and I think, I'll keep it relatively focused on a few areas. We talked about a number, but we're going to focus on functional skill development, academic consideration, and useful resources. And what I think you'll see is their needs are really so much more similar to those families with autism than those families who have a child who's deaf and hard of hearing. Functional skills were a big priority, and many of the parents talked about trying to find the balance between the academic performance and the social skills development. And really, they were more interested in the social skills and functional skills. And one mom said, at some point, I'm going to look back at him and say, it doesn't matter to me if you know your multiplication table. I can't take you anywhere. I can't take you to the grocery store. So this academic promotion was not their priority. They also had a similar theme across them, is that while they wanted their child in social groups, it was difficult based on geographic location, scheduling. Could they find time to do this within their busy schedule, even if there was a good group that their child fit into? And that's probably common across most families of kids with autism spectrum. In general, it was interesting because the parents in this focus group all came from pretty good school districts in terms of well-resourced school districts. But they were actually quite happy with the services they were provided, and that their school team really did take a broad-based approach. But they were worried about potential cuts in funding and what that might mean for services, what that might mean for access to an interpreter. And it seems like at every juncture, if their child was relying on an interpreter, would they maybe lose those services? They also appreciated that their schools might give them extended school year, but again, very similar to what we hear in kids with autism, the extended school year doesn't look like the year-round school, so that isn't so helpful for a kid who needs that routine and schedule and reliance on structured teaching. So while it was kind, it wasn't necessarily viewed as uniformly effective. And they really wanted better training of professionals for those working with their kids to really be proficient in both the aspects of permanent hearing loss and that of autism spectrum. They did find some good resources. They felt that schools were their primary resource for information and support, and they appreciated having good communication between their teacher and themselves, and it allowed them to practice at home. So it all depends on your teacher. We used to get materials to bring home that we could work on with her on vacation and on breaks. Now we aren't getting any of that. So this family was frustrated by a lack of clarity from their school on how they could follow through with things at home. Again, none of this is very different than when you talk to families with autism without hearing loss. They did find visual schedules to be very useful, and that the internet was a consistent resource that everyone used, which helped them learn about strategies to help their children network with other families and connect with professionals. They viewed the internet as a godsend. But the flip side of that is, even in the networking and connecting with other families, because deafness and autism together is such a low incidence disability, these families and kids are spread across districts. They're not in the same district. If you're even going to use the internet, you've got to have the time to do so, and how hard it is to really prioritize time online if it's, as compared to all the other priorities that they have for their child. So they felt like that was good, but it was still hard to do that consistently. So there are a couple of their wishes. Ability to observe outpatient clinic therapy. So some of the settings have in our system have video monitors and others don't. But they thought that was really helpful because then they could observe therapy and try things at home. And they really just wanted somebody that they could call or email with questions, and that person would be a good source of knowledge that really understood the dual diagnosis aspect, both aspects of what their needs were. So really, I think what we've learned is families want more information. Both professionals and families see better education of the medical and educational professionals as priority, and that communication is really key. So my take-home messages for the ATN really are pretty simple. One is please, please, please definitively evaluate hearing in all children with suspected ASD. I've had kids where I've really pushed to do a sedated ABR if you can't get good testing, because I see these kids who I found are deaf first and then have autism, but it can come the other way. Maybe if it's a milder hearing loss, the autism is what's notable first. And also, don't attribute features of ASD merely to the fact that a child has a hearing loss or a language delay. And then finally, I hope that the network can be part of solutions in building treatment programs for children with the dual diagnosis. The remainder of my talk, and we'll send that out, has a bunch of resources and articles and things like that. But we're now at a place where we can open it up to questions from the group.
Thank you very much, Dr. Wiley, for that presentation. If folks have questions, you can always unmute yourself and ask, or you can type your question into the questions bar and I can read it aloud for Dr. Wiley. So we don't have any questions right now, but if folks want to ask questions, we have about 10 minutes to do so.
Or you can be done early.
So it doesn't look like we have any questions right now. We have a couple people thanking you for your presentation. Oh, nope, we have a couple. Let's see. First question is, often do you see children who have relatively good nonverbal communication skills but show a lot of repetitive behaviors and meet criteria in other areas for autism?
So, yeah, I think yes, there are kids who are deaf and hard of hearing who have OCD features, if that's the question, but I think it becomes pretty tricky if the restrictive repetitive is the only area where you're seeing deficits. If you're not really seeing it in the other atypical language and social interaction, I wouldn't feel comfortable calling autism merely on restricted repetitive interests, as long as they're reasonably modifiable. So if I were seeing a kid that could only talk about certain things, well, that's a restricted repetitive interest, but it's also impacting my social communication and that sort of thing. I'm not sure if I'm answering that right, but I have seen some kids who really fit more anxiety OCD, And then you really take the approach to address those things and then see what happens from there.
Great, thank you. So we have another question. In children with profound hearing loss, if you remove a significant ID, do you see more ASD in this population?
If you remove intellectual disability.
Yes, yes.
Well, so that's a really good question, but one that I would not feel comfortable answering, because even the diagnosis of autism spectrum in the data sets we have, one could argue, is it accurate or not? So how was the diagnosis made? Was it made by professionals who know both fields? And these are the discussions that I've had with those, like Dr. Smazansky from Gallaudet kind of went, we don't know what's in the data set is accurate or inaccurate of label of autism. That's, I wouldn't know how to look at the data that we have and determine that. I mean, there's so little known. And, you know, I guess if I think about even just my own clinical population, there are kids with intellectual disability and autism spectrum and deafness or hearing loss, whatever. And then there are kids with average IQs with autism spectrum. So it really ranges just like within the range of kids with autism. I've got some kids with unilateral loss who fit, and I would really put a promotion for unilateral loss as not, you know, should not look autistic. I had one psychologist who wrote, the child didn't look at me, but that's to be expected because they had unilateral hearing loss, and it was a one-on-one testing setting, and that doesn't fit the hearing level. So I'm not answering that very well because I think there's probably not data to know.
Okay. Another question is, do you work with occupational therapists to develop treatment programs for children with a dual diagnosis of ASD and hearing loss?
Yeah, I mean, absolutely. So when I'm seeing kids with a dual diagnosis, anything that works for autism, you know, the sensory stuff, the sensory diets, the breaks, the, you know, the communication stuff, all of that really does apply. Just as you would determine that for a kid with autism spectrum, you would apply that same idea. In fact, probably, though, the flip side of that is there are a number of kids who are deaf or hard of hearing without autism that sometimes really benefit from OT because you do see sensory issues or attentional issues, and you know, sometimes we'll start there as a way to kind of build, you know, calming strategies and/or better attention and focus. You know, if it doesn't seem like autism, but those needs are there, I will suggest that as an intervention.
Thank you. It doesn't look like we have any additional questions. Oh, nope, here's another one. So the question is, this population is very understudied, as you've mentioned. If you could design your own study and have it fully funded, what would you most want to learn about this population?
Oh, wow. Boy, there's too many buckets of unknown. I mean, I would want a way to identify very early. I mean, I would want to understand how to identify earlier, but then more importantly, well, equally importantly, build interventions that are effective and then look to see that those interventions are actually effective. So, you know, if we could recognize these kids early and then intervene, what does that intervention, which interventions make the most sense and which are most effective for most kids? I mean, it'd be great to be able to figure out how to adapt assessment tools so that we can meaningfully assess kids, but yeah, I want the world, I guess. But I guess I'll put a plug for anything is better than nothing at this point. I mean, we are kind of at a case series place. I know of Christy Borders is a deaf educator. She's actually uniquely trained because she's trained in oral deaf ed, signing deaf ed, and then got her PhD in special education. And she's in Illinois, and she's really trying to look at interventions within the classroom for kids with a dual diagnosis. And I think that's where we're going to get the best likelihood for outcomes, is can we actually support educators to support these kids effectively.
think that's all great, and hopefully we can strive for some of those studies in the future. We have another question. If you have any recommendations for how to design a payment or reimbursement system that pays the provider for the provider communication levels that you have recommended.
Oh, yeah, wouldn't that be great? I mean, I think, it's tricky because school districts are really, like, I think of it in two ways. You look at the school district issues and the pressures they have for kids to perform well, and even their allocation of special education services, and then, is there a blog site people can go onto or work as a team? I mean, if you could get care coordination visits paid for that include telehealth or something, I mean, that might be a strategy. Often the parent is basically the conduit of information back and forth, and that's a tough place for them to be. And that's for all, that's all kids with autism, really. I'm wondering, if the person asking that question have like a way to modify pay schemes? Because the insurance company or something. If they do, we'll talk offline.
If they do, I can put you in touch.
Okay. Thanks. These are great questions.
Yeah, these are all great questions. Let's see, I don't have any more right now. So I will just, she says that she's sorry, but she does not have any connections for you to payers.
Okay. I didn't expect it, but I suppose that's something that, in terms of family organizations and medical organizations coming together, what is it that kids need across, disabilities? So it's an important component.
It is. So if there are no more questions, then I'll just remind folks that an evaluation form will be sent around after the session, and a recording will also be available. We have another question. How do children with deafness present with nonverbal learning difficulties?
Oh, that's a great question. My best example of that was an older kid. I don't know that you'll actually see their language actually going pretty well. So their language skills and their verbal problem solving doing well. I can think of a couple of kids I've seen who, one had a shunt, so it kind of fit the scenario. I had another boy who was auditory oral, and then he transitioned into the deaf school. Math was always his hardest. Sign language was his second language, and he was being taught by the math teacher who was a loved ASL deaf teacher, and his behaviors were worst in math. And when we actually ended up doing all the assessment and looking at, this is where your assessment batteries should include some verbal problem solving, because in the kid who's deaf with a language disorder or a nonverbal language disorder, nonverbal learning disorder, you will see lower performance and higher verbal, and then you'll see that map out in the areas of math or spatial recognition and awareness and executive functioning and that sort of thing. So yeah, it definitely happens, but it's the pattern that's opposite for most deaf educators, so they're often surprised to see that, because usually you're seeing more of a language deficit in kids who are deaf and hard of hearing.
So that brings us to our 4 o'clock time. So I would just like to thank everyone for attending, and thank Dr. Wiley again for presenting, and look for an email with additional resources and information.
Thank you.
Thank you so much. Have a good afternoon, everyone.